are about to start the final, but the best session of the summit so far. My name is Holly Holder, and I'm absolutely delighted to be here chairing the session. We're going to be talking about all things housing, health and care, which is something that reflects my career. I have worked across all three sectors, previously for the Nuffield Trust, lovely to see some familiar faces in the audience, also for NHS England, and I've been a trustee of a social care and housing provider. Recently worked for an organisation much more on the research campaigning side called the Centre for Ageing Better, where we work to make sure that housing was suitable for people across the life course. And most recently, currently, I work for an organisation called Campbell to Kell, and we're a consultancy that works primarily with local authorities, housing associations, NHS bodies, really helping them look at the services they provide and also how they themselves run as an organisation. And I specifically work, again, on that interface between housing and care, homelessness, rough sleeping, supported housing. So really excited for our fantastic set of panellists. But just to do a bit of scene setting, so the question we've been asked today is, will the state of England's housing thwart NHS's aims to move hospital to home? So I hope you're all buzzing with ideas and interesting questions to put to us. So across the health and care policy, the direction of travel is clear. NHS is trying to move care closer to where people live, and we see that through initiatives like virtual wards, hospital to home. None of this is new stuff, is it? And an ambition to support people to live as independently as possible at home. And the principle behind this shift is compelling. Most people prefer to receive care at home. It often leads to better outcomes, greater dignity, and more efficient use and effective use of hospital capacity. And with an ageing population and rising demand, avoiding hospital stays has become a central priority for the health system. But there is a fundamental question sitting underneath this ambition. What if the home environment itself isn't suitable for that care? And for many people, millions of people in fact, across the country, housing conditions present real barriers. Homes may be overcrowded, poorly insulated, damp, inaccessible, or simply not designed to accommodate someone recovering from illness or living with complex needs. Others might lack the space, the equipment, or the support required for safe care at home. And at the same time, we know that housing pressures are growing, particularly amongst the groups who are likely to be experiencing health inequalities and be living in poor health. There are long waiting lists for social housing. The impact is that many people of those groups are living in private rented, temporary accommodation, lots of others in housing insecurity. If you're living in a private rented accommodation, it's very difficult to get adaptations to allow somebody to remain safely at home. And even when you do get access to that support, it can take months or even years to arrange. So as the NHS shifts towards this hospital to community, the question becomes not just can services be delivered at home, but whether the home itself is ready for that care. And if the housing isn't adequate, we see the consequences showing up in the health and care system: delayed discharges, preventable admissions, increased pressure on carers, and widening health inequalities. So in other words, housing conditions can quietly shape whether or not some of our most important health policy ambitions succeed or struggle. So we're kicking off with two presentations, and then we'll move on to the panel discussion. Firstly, I'd like to introduce Martha Hall, who's an expert by experience working with Gloucestershire Health and Care NHS Foundation Trust and the Royal College of Occupational Therapists.
Good morning. So I'm also, because Chris Whitty let us down and didn't say next slide, please, I'm going to start us off strong here. So next slide, please, Lauren. Okay. I'm going to start off with a quote from Francis Ryan, a journalist, author, and disabled advocate. Disabled people are not inherently vulnerable. We are vulnerable when governments choose to withhold the resources disabled people need to live dignified and secure lives. Whilst I'm speaking today, I want you to think about this quote, and particularly how we can ensure that those we work with have dignity and security. Oh, next slide, please. Sorry, am I going to have to say that? That's cool. That's cool.
I'm many things, Martha, but I'm not psychic, so you're going to need to say out or wink at me or something.
I can't. Yeah, we'll go with that. I was born 2 months premature and diagnosed with cerebral palsy spastic diplegia at 20 months old. Growing up, I lived with my parents and 3 siblings. I used various pieces of prescribed equipment to support and maximise my independence. I was able to walk short distances unaided, and at 11 years old, I had major surgery, which allowed me to walk longer distances using walking sticks or crutches. Next slide, please. Side note, I just want to address, on the right, you can see one of my favourite photos of all time. It's the first time that I ever rode a log flume, and it always makes me laugh. I'm in the front, scared for my life. My dad's having the best time in the middle, and my brother is in a similar space to me. But I've always been adventurous and determined to prove that I can take on any challenge. My disability is by no means the thing that defines me. But for most of my life, most of my childhood, I found the label inescapable. At school, I would frequently have to do physio during lunchtime before I was allowed out to play. I also missed a lot of lessons to attend appointments. I was just a kid and I wanted to be treated the same as everyone else. Next slide, please. I began to resent my disability. Oh, hang on, I've jumped ahead, sorry. No, I've jumped, you haven't, I don't think. I spent my childhood under paediatric services with lots of specialist input from various professions. The message that I heard from key professions and the world around me was that my body was broken. Next slide, please. I began to resent my disability and my body. I wanted to be Martha and not my cerebral palsy. After years of my mental health being ignored, I was diagnosed with severe depression at 16 and referred to child and adolescent mental health services. This affected my education, and I missed so many lessons that I had to withdraw from school, the place where I'd felt most like Martha. I was tired of fighting for my voice to be heard over my disability, and I was angry at the world for not seeing me. It was all too easy for me to take out my sadness and frustration on my body. After all, it was never going to be good enough. The first conversation I remember having about housing happened when I was 18 years old, and I had been admitted to a psychiatric hospital for repeated self-harm and suicide attempts. I was admitted as an informal patient, but I'd previously been detained under Section 3 of the Mental Health Act as a teenager. I was told I would have to explore supported housing options post-discharge with my community team, but my parents and I knew that returning to the family home was neither safe nor viable. We were advised by a nurse on the ward that the only way to prevent discharge home was for my parents to make me homeless. This was a hard pill to swallow, but we felt like it was our only option. From the moment my parents were forced to make me homeless, I was unwittingly stuck between a bed crisis and a housing crisis, and it nearly cost me my life. My mental state declined, and I was once again detained under Section 3 of the Mental Health Act. My team began exploring supported housing options for when I was discharged. I told them I needed a level access property, a ground floor bedroom, and a wet room. I also said that I wanted to live in my hometown around all my family and friends. Sorry. The discussions about my housing and discharge were had by Health and Social Care. I do not remember the local authority housing services being involved, and nor was I. Over the following months, I was shown 3 placements. 2 of these were supported accommodation shared houses outside of my hometown. Neither of them had level access. The third option was a neurological rehabilitation centre. I have never had a neurological condition that requires rehab, and upon learning about my situation, being sectioned, the team at the centre were appalled that I was ever seen as a suitable candidate for their place at their facility. At this point, I lost all my trust in the system. It affirmed my beliefs that those looking for suitable accommodation for me were only looking at my diagnoses, and they were making assumptions about it. They were not seeing me as a whole person. During this time, I remained sectioned on the acute psychiatric ward. I was unsafe, and my self-harm was increasing in severity and frequency. I was introduced to a social worker who told me that they could create a bespoke supported housing placement in my hometown. But I had little faith because I'd already been in hospital for 8 months and it just felt like another empty promise. She said that I could either wait there on the psychiatric ward or I could be transferred to a secure psychiatric rehab unit that would likely be out of county. I chose the rehab unit because I thought the setup might be better suited to my needs and I was just desperate for something to change. Whilst at the rehab, things deteriorated. My self-harming did not improve, and after an incident that resulted in me being resuscitated, my team at home chose to bring me back to the local psychiatric intensive care unit, the PICU. This was to be a planned admission. I was told explicitly that regardless of my mental state, I would be being discharged after 2 months. Care plans were created without my input or without discussion. These care plans directed that if I was to tie a ligature, staff were only to intervene when I lost consciousness. They were to remove the ligature, take my observations, and not engage with me afterwards. The events of this admission still haunt me, and later on I would be diagnosed with complex post-traumatic stress disorder. The staff saw me as a young female with a personality disorder diagnosis. To them, I was an attention seeker and a bed blocker. But I was barely an adult. I had spent my entire life governed by medical professionals, appointments and hospitals. I felt I never had control over who I was. And despite my best efforts to be more than a diagnosis, this was all I was ever allowed to be. I never learned how to be a child, a young adult, or how to independently navigate a world that was inaccessible. Learned helplessness is a psychological state in which an individual believes that they have no control over negative events, leading to passivity, decreased motivation, and a sense of hopelessness. Upon discharge, I can remember feeling bewildered, worthless, and traumatized. I was completely unprepared for the outside world. And although there were support workers in situ 24/7, they were unqualified and ill-equipped to support me and my level of self-harm. What followed was years of being a revolving door patient. And despite the neglect I had experienced at the hands of the psychiatric intensive care unit, the PICU, I was so institutionalised that I didn't know how to function outside of hospital. It is where I felt safest. The property that I was moved into was privately rented, and so it was not secure. This remained my home address for 10 years, until I was served a no-fault eviction notice in November 2024. At this point, I fell at the mercy of the homelessness process. Despite having grown into an assertive, informed and confident woman, navigating the process was daunting and humiliating. In my first phone call with the housing officer, I was told that declaring yourself homeless is a choice, and it's not for everyone. I had to prove to my local authority that I was not making myself intentionally homeless. Whenever this term was used, I felt like my integrity was being called into question. I had to provide a detailed breakdown of my monthly income and expenses. And although I expected to have to share my bank statements, I did not expect to be interrogated. I was forced to divulge sensitive information about what my disability and mental health condition cost me. I had to tell them things that I would never have chosen to share with them. It was deeply humiliating. This process triggered a relapse in my PTSD, as I felt so exposed, unsafe, and degraded. I was begging for the tiniest sliver of dignity, whilst waiting to be told I had been deemed worthy of being rehoused. At one point, a housing officer referred to the cost of my assistance dog as a significant outgoing. To say this is to suggest that the cost is high and unnecessary. This further demonstrates that their lack of understanding of what it is and what it costs to live with a disability, and emphasises the lack of lived experience in service design and staff training. It also speaks to their inability and unwillingness to look at the bigger picture. Greg is legally classified as a mobility aid, but he is so much more than this. He's my lifeline. Since we were partnered, the hours of care that I receive have halved. My overall care package now costs around £36,000 per year, and that includes all of Greg's costs to the charity Dogs for Good. But over all the years I was in hospital, it cost between £110,000 and £220,000 per year. He is the reason that I am mentally stable and physically stronger. He's the reason I'm here today. And before Greg came into my life, I never left the house. I could barely walk down the street. And now I love spending time in nature, and I can walk at least a mile a day. Everyone around me can see that Greg is invaluable. Within days of my impending eviction, I was finally given temporary accommodation. Whilst this was, of course, a relief, the temporary accommodation was far from ideal. Despite my occupational therapy report stating that I needed wheelchair-accessible housing, I was given a property with no level access, which confused me because it already had a wet room. I could not use the main entrance to the building, nor my own front door, as they were too heavy. I fell twice outside because I was navigating steps and curbs without purchase. I did not require medical treatment for the injuries sustained, but they could have resulted in hospitalisation. And if I were to suffer a broken wrist or hip, the consequences would have been catastrophic. I spent months trying to get adaptations made to this property to make it safer for myself and future tenants, but nothing significant was ever done. At a different time in my life, the stress and anxiety caused by this process would have landed me back in psychiatric hospital, which would have solved the housing problem. A rough cost analysis suggests that 1 week in a psychiatric or a general hospital could cost between £3,500 and £7,000, depending on the level of care and treatment needed. Temporary housing is a grey area when it comes to disabled facilities grants and funding for adaptations. I was left in an unsafe property due to bureaucracy. An OT report, occupational therapy report, recommended access buttons to enable the use of the front entrance, a galvanised handrail, a drop curb, a porch light, and a scooter charging point. These were not objectively difficult or expensive, and they would have made my life so much easier and safer. And all of the things that I needed would have benefited other residents and the public. It is difficult to price all of these recommended adaptations, but I would be surprised if it was the case that the overall cost of them were to exceed £7,000, and certainly if it did, they would pay for themselves over time. It is difficult to see how the adaptations could not be considered cost-effective, especially over the medium to long term. Oh, sorry. Greg and I are now permanently housed in a home that meets our needs. A massive weight has been lifted and I feel like I can breathe again. The whole process lasted 13 months, but I know others can spend years stuck in this process. Years without security and fighting to keep their dignity. My hope is that one day we will have a system that collaborates with individuals and their families, as well as with one another. A system that works in partnership and not in silos. A system that sees a person and not a budget, and a system that recognises the importance of having a place to call home.
Clapping for you. Good boy. Clapping for you.
Thank you.
Lauren.
Thank you.
Well, I mean, follow that. Yeah, I'm delighted to be here. My name's Lauren Walker. I'm an occupational therapist, very proudly so. And my day job is with the Royal College of Occupational Therapists. One of the ladies in response to Tone's presentation made the point that there are no stories without data, and there's no data without stories. I can't possibly tell you a better story, a more powerful and insightful story than Martha has shared. So I'm going to share some data, sorry, as is my wont. And I'm going to start by stating the bleeding obvious, actually, which is that the link between our homes and our health is absolutely integral, completely inarguable. If there is anyone in here who would argue that there is no link between our health and our homes, I would strongly suggest that you leave. I would question why you were here. Quite frankly, I really hope that's not an argument that I need to win with everybody, with anyone. We know this. We've known this for decades, literally decades, that there is this inextricable link between how well we are and where we live. I'm not going to read out these quotes. I would hope that at least some of them are familiar to you. It's written into policy, probably not as much as it should be, but health is mentioned in housing policies, housing is mentioned in health policies, within care policies. The two things that I do want to mention from these quotes is that the top centre one and the bottom right, because I think Tony is absolutely right in that it's far more powerful and far more effective to focus on hope rather than despair. So the fact that unsuitable homes are costing us societally a fortune gives us an opportunity to change something. If we focused more on housing and improving our housing and making sure that our homes are fit and safe and enabling for everybody, will save us billions. Quite literally, billions. Also, I found it really striking. I hadn't come across the bottom right quote until I was preparing for this presentation, so thank you, co-pilot. I did check my sources. It is accurate. But 3/4 of health workers see people whose poor housing is likely harming their health. That means that if 3/4 of us, at least, are encountering those people, 3/4 of us have an opportunity to do something about it. And that opportunity will be different for every single one of us, depending on our role, depending on where we work, depending on who we work with. But we can all do something. I genuinely believe that very, very strongly. To focus a little bit, again, on the negatives, the negative data, housing is by far, by some margin, the single largest cause of mental health discharge delays. All of these statistics come from a report that the National Housing Federation did in 2024. So we could argue that these stats aren't bang up to date. They're a couple of years old. If anything, I would suggest that they've probably got worse. So the fact that people don't have somewhere appropriate to go home to is a huge blocker to the shift from hospitals to community. I think Holly posed the question, you know, the framing of this session is, will our poor housing thwart that shift? Yes, is the short answer. If we don't do anything about it, yes, it 100% will block that. But if we flip that on its head, that means we have an opportunity to do something. If we focus more on housing, we genuinely have an opportunity to make that shift happen. So that applies whether you're in a mental health setting, it applies whether you're in an acute hospital, it applies whether your home is supported housing, whether it's residential care, whether it's a care home. It doesn't matter. The existence of an appropriate place to live is transformative if it exists, and massively disabling, massively limiting, massively dehumanising, dare I say, if it's not there for you. My background is as a housing occupational therapist, so I feel very, very strongly about the opportunity of creating homes that are suitable. I take a huge amount of pride in what I've been able to do as an OT in terms of making sure that homes are, and Martha, I'm going to nick your quote. Martha said to me last night over dinner that our homes should open doors for our lives, they shouldn't shut them down. And I think that's absolutely right. And be that about adapting an existing property or building homes that are accessible from the outset, I've seen firsthand how transformative that can be for people. But only 13% of homes in England are currently even visitable for a disabled person, for a person with a mobility challenge, which means that 13 million people are currently living in homes that don't meet their accessibility needs. We have an opportunity to change that, And the government consulted on this a few years ago. So in 2022, the then government put out a consultation about raising the mandatory minimum accessibility standards of all new homes in England. So raising it to, if any of you are familiar with Part M of the building regulations, Part M42. So creating a M42 on M43A and B. Sorry, I've been out of clinical practice for a while. But making sure that every single new home had a certain benchmark of accessibility. So my clinical practice as an OT has been in London, and there are certain parts of the country that already have this minimum standard. And what that means is that if someone's needs change over time, for whatever reason, be that because they've had an illness, an injury, a disability, or simply getting older, that their home has features designed into it that will make it easier, quicker, cheaper to adapt. And that's great for people who are disabled. It's also great if you're a parent. You know, having a level access threshold, having wider corridors, means that it's easier to bring a pushchair in and out. It means it's easier to bring a suitcase in and out. Having a ground floor bathroom, if you're someone who experiences incontinence or an urgency to urinate, for example. There are very many reasons why having homes that have a certain level of accessibility built into them are a very good idea. It's not a niche specific thing for a small percentage of the population. We will all benefit from that. The outcome of the government's consultation was that 98% of respondents agreed that we should build a minimum level of accessibility into all our homes. 98% of people. If you can tell me a consultation that has had, any other consultation that has had that amount of agreement across sectors, including the housing sector, dare I say, this wasn't just people like me getting on a soapbox. Everyone agreed that it was a good idea because it very clearly is. However, it's still not happened. 4 years later, it's still not happened. The current government has written a proposal into the current national planning policy framework that around 40% of new homes should be achieve Part M42. Why? That's not good enough. I'm going to climb down off my soapbox, but you can see how passionately I feel about this. We know this is a good idea, so why aren't we doing it? It's also completely frustrating because, as I say, if we don't improve the inhabitability of the places where we live, and that is about accessibility, it's also about safety in terms of cold homes, damp homes. We've seen the introduction of AWAB's law and why that has come about. If we don't do that, we're not going to achieve these 3 shifts, end of. But if we do invest time, energy, resource into housing, it will be an enabler. It will make things better for everybody. So if our idea is to get people out of hospital sooner so that they can recover well in their homes need to support that. They need to have the space, for one, for people to rehabilitate and to have support with that if needed. In terms of analogue to digital, the conversation around digital health drives me mad, and every single time I hear a conversation about that, it's focusing on diagnostics and genomics, and those things are both incredibly important. But there is so much potential for both specialist and mainstream apps that we can all have in our phones and our pockets that will enable us to rehabilitate and live well at home. Who has a Ring doorbell? Who has an Alexa in their home? Both of those mainstream bits of kit are incredibly helpful for people. For example, someone living with dementia who may need a reminder to take their medication. Alexa will do that for them. We're not talking about radical, expensive, specialist, bespoke equipment. We're talking about things that exist in most of our homes, but we need to have the technological capability to support that. And in terms of sickness to prevention, our system is really reactive. So again, as a housing occupational therapist, a lot of my interventions went in after a point of crisis. So after someone had fallen and fractured their hip and had a hospital admission. In order to be preventative, we can do things before we know they're going to happen, and that is still incredibly cost effective. For anyone who's as much of a geek as I am, there is a brilliant randomised control trial that was published last year called Bath Out 2, which has demonstrated pretty unequivocally that if we install level access showers for people before we think they really need them, and again, who's they? Who are we to decide whether or not someone needs something or deserves something? But if we complete that intervention sooner, it's better for the person, it's better for the professionals, it is better for the public purse. Everybody wins in these scenarios if we think about people's homes and how they can enable and prevent injury, illness earlier on. So why does all this happen? I'm hoping that you agree that what I've said is true. So what do we do about this? Like, it's really easy to sit here and wring our hands and go, oh, isn't it so difficult? There's loads that we can do about it, and there is really positive work that's happening, but the system just doesn't really enable it at the moment. So we know that there are these links between housing and health and social care, and my apologies, I should absolutely have included the voluntary sector and hospices within this diagram. But the relationships that we have with each other are incredibly transactional, and we know why that happens. It's about accountability, it is about funding, and actually, especially with housing and with social care as well, very often the investment that we make from our little pot of money is more likely to be seen within the NHS. That quote that I put at the beginning is that if we invested in homes, the NHS would save 1.5 billion. You know, let that sink in. Part of the reason we're not doing that is because it's social care and housing who are paying for it, but it's the NHS that are finding the benefit. So how do we draw those worlds together? Well, we have a huge amount of opportunity. This is what we want to get. It's not about different silos talking to each other, like Martha, what you were saying. How do we genuinely work more collaboratively? Because the infuriating thing is that we're all working with the same people. You know, Mrs. Jones, who rocks up at hospital with a fractured neck of femur because she's fallen in her bathroom, is the same Mrs. Jones who will go and see a community service, who will get reablement for a few weeks, who at some point down the line might see someone like me who then installs a level access shower for her. We are all working with Mrs. Jones. We all want her to live well, have a good quality of life, as well as a hopefully long life. So we need to think in a much more person-centred way. We all say these words, person-centred, but how much are we doing that? You know, Martha, your experience is it sounds weird to say a perfect example of that because it's an awful example of that, but you weren't listened to, you weren't involved in so many of the conversations about you, about your life, and that is wrong. So that person on that diagram is Martha, is me, is all of you, is Mrs. Jones, but it's us as health professionals as well. So at the moment at the Royal College of Occupational Therapists, we're working on a project which is currently titled Housing Without Delay, and that is recognising the fact that we as occupational therapists are in a it's not a unique, it's a unusual position that we are ideally suited to be the ones bringing these three worlds together, partly because we know damn well that people's physical environments have a huge impact upon how they are enabled or disabled in terms of being able to live the life that they want to, in the way that they want to, with the people that they want to. But also we work in all of those sectors. We work in housing, health, social care, the voluntary sector, hospices. We understand those different silos. We understand the different pressures and the different opportunities. So we are a health profession that can bring those worlds closer together. And Housing Without Delay will launch in June in the House of Lords, which Martha and I are both very excited about. We're going to get a really nice cream tea. So yeah, please, obviously I'm doing a sales pitch because I work for RCOT, but genuinely our intention is it's going to be very enabling for professionals like yourselves, be you in strategic, operational or clinical practitioner roles in terms of bringing those worlds together. To go back to that quote at the beginning, 3/4 of health professionals are working with people whose poor housing is affecting their health. So we all have the opportunity to do something about it. So what's the value? I'm not going to over-egg this because I think we all already know this, but again, this is thinking about the value to different parts of the system, and just because I am employed by the local authority doesn't mean that I should just care about the local authority bit of this. We all need to kind of lift our heads above the parapet, get beyond our silos of working, our organisations, and think about the wider benefit to society, to the system, most importantly to individuals. And again, I've missed a category off here, and that is about the workforce. Now, there was a conversation last night about why is the NHS workforce so unhappy? Which I didn't attend, I couldn't bring myself to. But I think if we're thinking about how do we make things better, we know from our own workforce that the really high majority of occupational therapists, over 90% of occupational therapists, are extremely proud to be OTs. And yet, a disturbing percentage of them are thinking about or planning on leaving the profession because what they want to do as OTs isn't what they're enabled to do. So if we enable people to live well in the place that they want to live, that is good for the workforce as well. This is my final slide because, like I say, it's really good to sit here and wring our hands and go, oh, isn't it terrible, and nod our heads and go, oh, yes, we're all progressive activists. Be active, do something. We can all do something. And these are just a few thoughts about what the opportunities that we have. Be curious, have conversations. There are systems out there that are doing really good, clever, innovative work in very, very difficult circumstances to bring these worlds closer together. So seek them out. Read Housing Without Delay is going to be riddled with case studies and service examples. So find out what your neighbours are doing in other parts of the country. Talk to your counterparts in housing and social care and health. Like I say, we're all working with the same people. So start with communication with each other, with the people that you serve, with the communities that you serve. I know there are those of us in regional roles, and they're now about to take on the role leading an ICB. Again, I think ICBs have the potential to be a huge enabler because you can really intentionally and meaningfully invite housing into the conversation and make those shared decisions about commissioning. How are you going to do the best by the people that you serve? And finally, at national, please, for the love of God, if there's anyone in here who is a civil servant or works for DHSC or MHCLG, please implement the accessible housing standards. Everybody wins if we do, but also that argument against siloed working very much applies at a national level as well. Those of us in strategic roles, we need to be talking to our health, housing and social care counterparts. None of us can do this in isolation. We have to work together or we're on a hiding to nowhere. So that is my call to action to you. And on that, I will hand the floor back to Holly.
Brilliant. Thank you so much. So now we're going to hear from our two panellists for some initial reactions to what you think about the state of our housing, how it's impacting the NHS and helping or hindering people to live healthy, long lives. Nena.
So Lauren has called me out as I am about to start a new role as Chief Exec of North East London ICB. I'm currently Chief Exec at North Mid, also Honorary Professor with the University College London Global School for Health. I'm sitting here feeling an incredible sense of sadness and shame. Martha, thank you for your story. And the power of stories to supplement studies has been demonstrated today incredibly. I have not been able to stroke Greg, although I've been really tempted for most of this. And I am also struck by waste and harm. And there is so much to discuss in this space. We know that the social determinants of health are less about healthcare and transactions. We know that 80% of the change we can make to people's lives are not about what happens in a hospital. And housing is a fundamental part of that. I'm also delighted that the language we use was not just about housing, it was about homes. And that is a distinction that's really important. Maslow's hierarchy tells us about the need for security and the need for safety. And I hope many of you have had a chance to look at the exhibition, which reminds us that even when people have houses, sometimes those are not safe places. Those are not places of security. And there is something about the conversations we have in remote buildings that's very different from the reality of people's lives that we need to hold and hold responsibly. I can talk about the the theory of the shifts, and the shifts are not just about the physical aspect of a house, it's also about our risk appetites, it's also about the technology that we put in place, it's also about our models of care and our workforce, and we know that those are all, for different reasons, quite challenged. We talk about homes as though they are just the domain of the individual. We also have care homes. To think about care homes are people's homes, and how we treat people and build communities within those homes are equally important to what we do for health. But I'm really struck, Lauren, you've really agitated me positively.
Oh, good.
And there's good work done, and you're right. It's not about reinventing the wheel. There's something about how we take what is good and magnify it. So I know about coalitions between health and housing. And as I move into an ICB in London, that is something we want to replicate from a partner ICB that's doing that work. The artificiality of budgets is incredible. And I spoke about waste. I mean, waste in terms of money. How much money? £1.4 billion it costs the NHS. And that's the stuff we can measure. The stuff we can't measure. We can't measure the damage to pride and purpose. We can't measure the damage to physical and mental health. There is so much that we can do if we are all just considering not that this is my budget, your budget, but what is the need of the individual. And so how we look at our collective budget is going to be a huge part of what we do differently. I'm really conscious that, yes, I want to talk about homes, but just to talk about houses for a minute, the stock of houses that we have is insufficient. And that's not just the quality, this is the actual stock. We're in London, our population has grown by 8%, but our housing has only grown by 4.5%. That is an equation that never balances. And then within those houses, you have situations that are just not suitable and drive consumption of healthcare. So Awaab's law is an important law. Overcrowding is an important element, and it impacts not just health, it's education as well. And we need to think differently about what it means for houses that were built in almost antediluvian times, and their sustainability and their contribution to climate challenge, and what that means in terms of people making trade-offs in terms of heating, in terms of food. So this is a multifaceted problem of which health is just one manifestation. So that diagram where we all work together is really central to how we move forward. I do want to talk about staff, and that we spend a lot of time talking about patients, and that's right, but I'm also really conscious that affordability for staff is an issue as well. And that means that when we're talking about the workforce to deliver in care homes, in hospitals, in community settings, we're not always able to have our staff afford to live and to be able to be recruited into those spaces. I am excited. The ICB I'm going into is expanding, huge housing opportunity. And just listening to what you've said, just making sure that the minimum standard is delivered. But I'm not about minimal. So I might show my age here. How many of you remember a show called The Jetsons? Okay, right. So that was a very futuristic way of looking at housing. And I think it goes beyond Alexa. It goes beyond accessibility standards. It starts talking about how do we build modern houses that look at the risk of falls, etc. Because if we project our population forward, we're going to need to think differently about what we provide in terms of housing for the future. There are other aspects that I can go to, but I think there are other voices to come in. There's a lot that I feel committed to start. And we also talk about the difficult, easy in management terms. We're wasting money, we're wasting time, we're harming people. We need to do more between housing and health and care and all the sectors working together. And Martha, your story is just incredibly impactful, one that I will repeat. Thank you.
Thank you.
Thank you.
Wow, where do I go from there? It's been a really powerful discussion. So, Martha, your story is really inspiring. Lauren, your experience as an OT, again, really powerful. And then, your insights are really important in that kind of emerging healthcare system. So, I'm Ansaf Azhar, I'm Director of Public Health for Oxfordshire, but I'm also a Association of Director of Public Health board member. So, I'm going to bring a little bit of a sort of a population perspective. I'm not going to be blinding you with slides. I definitely won't be saying next slide. But actually, but before I do that, let me just kind of take you through a personal journey as well. So my career, kind of nearly 25 years, 23 years in public sector, half of it was in the NHS, half of it was in local government space. So I kind of see some of the culture changes, culture differences between the two settings. And I'm sure many of you will kind of reflect on that as well. When I started my career as a clinical pharmacist back in 2002, it was clear I was treating patients, I was discharging them, involved them in the ward, in the clinical pharmacy setting with the medics, but we were therapeutically fixing patients, sending them back home, and they are literally back in 3 months' time. You know, if you're in first name basis with the patients, you know, you know, long-term conditions, COPD, cardiovascular disease, things like that. There was nothing wrong with the way they were discharged. There was nothing wrong with how we medically optimized them before discharge. But guess what? We send them back to the same living conditions that made them ill in the first place. No one spoke about that back then. I think there's a really positive discussion happening at the moment, but no one spoke about that then. And it was kind of a driving force for me personally to think about public health. We spoke in the last couple of days, yesterday and today, quite a lot about healthcare system, quite rightly so, because, you know, if you look at our population demographics, where we're going, I think it's really important to reflect on what is the future health and care system would look like. But as you said, the health and care system only accounts for 20% of the population's health. The rest of the 80% are the wider determinants of health. And the return on investment, the value is absolutely massive. And here's the other thing, Councillor Baroness Casey yesterday talked about life expectancy going up, you know, and it's gone up quite considerably over the last 50 years. By 2040, we're going to have double the population of people living over the age of 85, one third more living over the age of 65. So how are we going to manage that system? We need to talk about the culture, and we had an earlier speaker talking about those cultural side of things, but how are we going to manage that? Are we going to continue to expand our health and care system? No. And the other side of the coin is that we haven't spoken about enough is the healthy life expectancy. This is the number of years you lived in good health. That hasn't gone up at all in the last 20 years. In fact, it's been falling. So we've got healthy life expectancy that's hovering around the age of 60, but yet we are actually treating people and medically optimizing them and making people live longer, which is a great thing. But just think about that at the latter end of their life. So if you think about how we can improve people's healthy life expectancy, the housing has a key role to play in that, and not just as a way of actually creating accessibility, creating inclusive homes for people with long-term conditions to live effectively, people with disability and so on, but also about keeping people healthy in the first place so that they don't need care, or they minimize the need of care, or they delay the need of care. This is really, really important. And I think in the current climate, we have a real opportunity to break down some of these silos between health, social care, wider determinants of health, local government sectors, occupational health, and things like that. And for me, I think if you do one thing, it is about breaking down those silos. Because the other thing that we haven't spoken about enough, I think, in the last couple of days is inequality. You know, in the southeast region, we are one of the most unequal regions. Some real affluence and some real deprivation. And Michael Marmot often talks about the inverse care law, which means that those who most need the service, most need an intervention, are the ones that least gets it. And I think from a housing perspective, where do you think those who are living in overcrowded areas, those who are living in poor quality of housing, those who are struggling with the affordability of housing, those are all from the disadvantaged, deprived areas where the health and care needs is massive. So how can we address that? And I think it's really important that also recognizing where the demand for the health and care system is coming from. They're coming disproportionately from these communities. So there is a moral argument, there is a value-based argument, and we can't delay that. And I think that is something that we can do by actually thinking this thing as a whole system approach. And guess what? There are some great work happening. Not at scale, but there is definitely some great works happening. There are health and well-being boards in local areas that brings all partners together, from acute hospitals to local government housing services, all coming together. What's stopping us having our local conversation at that space? There is data and intelligence that looks beyond our health and care data now. We're starting to integrate our data system together around understanding the conditions in which people are living their lives, the quality of housing, fuel poverty, and all those kind of things. We have an opportunity at a local level to pick that up. Integrated care systems and other systems are getting truly integrated, which allows us to have those kind of discussions. We also have the neighborhood health agenda. I know the neighborhood health agenda is about actually how can we deliver clinical services in the community in an effective way. But what a fantastic opportunity to talk about the wider determinants of those communities, their housing, the spaces that they're living in, and so on. It'll be a real opportunity miss if we don't combine that together in that space. So I can go into a number of examples, but I think we've got to look at it from two perspectives. One is how can our homes be better suited to deliver care in an effective way, but also how can we use our home and housing as a real determinant of health to keep our population healthier for longer. I think that's also equally really, really important. Thank you.
Thank you for such passionate and informative comments. Now, let's open it up into the room. What I'm hoping to hear is some really good ideas about what action you're going to be taking, how you're going to move away. Housing isn't just about building new homes, and there are practical things, as Ansaf just said, that you guys can take away and do in your own practice. But questions for the panel? Anybody got any? Here we've got one right at the front, and then the lovely green pattern. Thank you.
Hi, I'm Katie Saunders. I'm Chief Exec at the Windsor Foundation. But more than the organisation, more than the title, I think like most people in the room, I'm an activist, I'm a change maker, and I care deeply about reducing inequity. I am in a privileged position where my organisation has earmarked an initial £3 million to try and shine a light on that best practice, to try and break down silos. I have held public sector roles as well. I know 3 million is a drop in the ocean, but I also know that used in the right way, it can be precious seed capital, precious transformation money, and it can ignite some of the joy that we've been talking about over the past couple of days. So my question to the panel is, if you were me, what would you do? And then I guess to the floor, if I haven't already spoken to you about this, please come and speak to me as well. But yes, what would you do, panel, if you were me? How do I use this precious, precious gift?
Thank you. If we can take the second question as well.
Oh, thank you. I'm Fraser Batty from the Stressed Units. We're a team known for the quality of our quantitative analysis, so I've just done some. The 10-year plan for the NHS mentions the phrase social determinants twice, and it mentions genomics 37 times. My question for the panel and for the room is, is the current policy direction actually working against what you're advocating for here?
Brilliant, thank you. Well, I mean, the first thing to say is, Katie, don't apologise for 3 million. We love the Windsor Foundation, you're doing great stuff. Does anybody on the panel have any ideas about research or activities that they'd like to see funded that would help that space?
I'm happy to kick off with that. I will literally rugby tackle you at the end of it. So yeah, I'm going to talk a little bit about housing without delay, which we have a significant significantly lower budget for. But in terms of how we've structured that, so we recognise that there are multiple audiences that we're talking to, because it isn't just the housing sector, it's not just the health sector, it's not just the social care sector. It's all across, so it's those national decision makers, it's managers of services, it's leaders of ICBs, and it's the lowly clinician who's out there actually doing the doing. So how do you not try to be all things to everyone, but how do you tap into all of those people's worlds? Because I think, you know, this event is a perfect demonstration that people aren't apathetic, people don't want to make change, but there are things that are preventing it. So how do we position ourselves as a solution to people's problems? Because it's not that people don't care, it's a lot of the time it's because they don't have the time, they don't have the money. So how do we get past that? Because like Ansab says, there is really good work happening. So I think it's sort of shining a light on the positives and giving people the ammunition that they need to do stuff in their area. So Housing Without Delay is going to be formed of 3 different things. We've got a strategic report which highlights the data. It kind of makes the economic, the moral, the social, the quantitative arguments behind this. We've also got an operational toolkit which is designed for people like Nena, for people who are in kind of leadership roles but in kind of an operational space. So managers of occupational therapy teams, but teams that are wider than that. So how do you make that business case? What does that look like for local commissioning? And then we've got a practitioner toolkit, which is aimed very squarely at occupational therapists. So maybe your opportunity is to look at the wider workforce because the opportunity that I would have as a housing OT is very different to one of my OT counterparts who's working in an acute hospital, is very different to one of my counterparts who's working in a hospice or in a community rehabilitation team. But every single person we work with lives somewhere. And that might be their own home, it might be residential care, they might not have a home, they might be homeless, but we all have the opportunity to have curiosity about that and to do something about it. So as a housing OT, I have the opportunity to help them to move somewhere more appropriate, like thankfully has finally happened for Martha, or adapt a home. But it could just be a conversation, it could be signposting, you know. So I think it's empowering ourselves as interested individuals, whatever our role is, to have some impact. You know, how do we take this from good intentions to positive action?
So I'm sort of trying to avoid my tendency to say just give all of it to my new ICB, that's fine. I do think though that there is good practice that we're not aware of, and rather than reinventing the wheel, it would be really great to create a repository that says here are the things we could do without necessarily needing funding or resource. Here are the things we need to do collectively to lobby for a different position, and here are the things that might need resource, and this is the quantum of resource. So there's something about how we use that, as you say, to seed the way forward, using existing examples that I'd be really excited to look at. And Fraser, to your question, and I'm really delighted that I'm also a trustee at the Nuffield, that this is the space that we're having these conversations. So when you challenge us around, is policy working against this? I think this is particularly a great space that says, what is it we need to be looking at? That may not necessarily be written in the conventional documents, but is really pertinent to what we need to do. And when I took this role up, what I really loved was strategic commissioning, and I don't think that's a thing that existed. It's a thing that is emerging, and so we have the opportunity to create something based on the data. So when we look at our joint needs assessment, housing is now part of that. We look at population data in a different way, and I think there's a real opportunity for us to weave those two together to make sure we're having the same conversations in the same room, looking at coalitions around things that we do, not just discuss as we move forward, and looking, I mean, I'm on a public stage, but you know, forgiveness not permission, or probably neither forgiveness nor permission. There's stuff that we can just get on and do, using neighbourhoods as a way forward, using strategic commissioning as an emergent tool.
Just building on that a little bit, so I absolutely agree, and I think £3 million is actually quite a good sum of money, because some of these things don't take a huge amount of money to do. It's not like some of the very expensive clinical interventions. These kind of social determinant solutions are not expensive. It just needs commitment and scale to do it over a longer period of time to make a real difference. So I would just use just one principle: break down the silos. So particularly around health and housing services. So in my local patch, we have a service called, and I'm not advocating for that, there'll be other examples like that as well. So we have a service called Better Housing, Better Health. These are people who go and visit their housing estates for various reasons, because of a broken window or whatever it is. But we incorporated a healthy health and well-being component to it as well. So we look at their mouldy houses, referred them as, some of the patients who are living there, COPD patients, made the health link. And we evaluated that program, which showed actually reduces healthcare demand, it reduces hospital admissions and so on. So there are some pockets of really good example, and that's not unique to our local patch. There are examples like that. But the principle is bringing healthcare and housing together. And I think that if you apply that one principle, we've got lots of opportunities. Neighbourhood health plans are coming up as we speak right now. So can we use that as a platform to deliver some of those principles? In Kent, I believe they have something called the Hospital Discharge Service, which is all about when people get discharged from the hospital. They look at before they get discharged, they look at their housing conditions before they move into their homes. So, and then they make adjustments, address some of the housing needs. And then what they find, the readmission rate was significantly reduced as a result of that. Really massive return on investments from that point of view. So I think keeping it simple and actually linking housing with health services, and now is the time to do exactly that. And then the bit about your policy question very quickly. In a way, yes, it's mentioned twice, but actually if you take the principle of the NHS 10-year plan, it's a 10-year plan which allows us to focus longer term. And I think there's nothing stopping us forcing ourselves to focus on more of those social determinants through the work that we do. And I think there is an appetite for that. Yes, there is an appetite to reduce waiting lists, and there's a political driver to achieve results fairly quickly. But it is up to all of us to keep the conversation going and really push that shift to more upstream prevention and wider determinants.
Thank you.
Yep.
Martha, something linked to that, which is there's a lot in all of the policy documents at the moment about prevention. And you and I before this were having a conversation about prevention and risk and who owns that. And we've had a lot this morning about risk. And we were sharing a story of, actually last week I was in Slough. Let me tell you, want to talk about health inequalities and housing inequalities. I was talking to people experiencing homelessness and rough sleeping in Slough. The taxi drive from Slough to here, it's a whole different story in terms of the wealth that we're actually in the physical place that we're in now. I was talking to two young people living in a homeless hostel,
Yep.
One of whom had been rough sleeping, only had good things to say, had been picked up after 2 days of rough sleeping, really appreciated all the support from the council, had been moved very quickly into accommodation. Somebody else who had been sofa surfing, so technically had a room over their head, waited months and months and months and months. Very little communication, felt very, very stressed about what was going on. And now, luckily, both of them are in very good situations, so that's fine. But we're talking about the policy shifts here.
Yep.
And you and I had a conversation about how do you actually support people? How do we create a system that doesn't wait for people to be in an absolute crisis position before somebody steps in to help them? And I just wanted to talk about that a little bit more, and also that question of risk.
Yeah. So, can you remind me of what I said? Because I've said a lot. We've had a lot of conversations.
Yeah, so when we were talking about, on the risk point, it was about who makes that decision and who takes that risk. And how,
I think that it's so important that we involve the people that we're working with, because traditionally speaking, risks have been decided and driven by policy and enforced by healthcare professionals, rather than actually the focus on being on safety, which I feel like when you start to think about safety, you immediately kind of have to level the playing field, like reduce, like get rid of the power imbalance and invite that person into that space and decide and have those conversations about what feels safe to you. I mean, I spoke about in my talk about how when I was on the PICU, the psychiatric intensive care unit, despite everything that happened there, for years, hospital was the space that I felt safest, and only once I started to have those conversations with people where they were actually listening to what it was about hospital that made me feel safe, it was because there were people around me, and I'd lived my entire life surrounded by people that were kind of holding me, and I wanted like long-term psychology in the community. That was my one request for years, and it wasn't done until I had gotten really, really poorly. Am I answering the question, or am I just giving a roundabout another story? No, we're doing good, all right. So I think that it's just absolutely vital that we start to invite people into those spaces, that we start listening to, I've lost my train of thought.
That's okay.
Got lots of big thoughts going on, and it's all like conflicting.
Brilliant. Okay.
But
Well,
sorry.
Do you mind if I piggyback?
Yeah.
Because again, we've had lots of conversations about risk, and again, it feels like it's been a bit of a recurring theme through the summit. And I think we demonise risk, and we see it as being inherently bad. And like again, Tony, you sort of talk about some of the unintended consequences of that, and by stopping someone from doing that because we perceive it to be risky, actually you're creating a knock-on effect of completely different so-called negative consequences. Like, it is literally written into my professional standards as an occupational therapist that I support people to take risks. So I think we can deceive ourselves that legislation says we must keep people safe, we must wrap them in cotton wool, we must prevent bad things from happening to people. And actually that's not always the case. And I think, again, because my background is from working in the community, I think those of us who are clinicians who have that community background and are working with people in their own homes have a much greater appetite for enabling risk. And that is partly about power dynamic, because we're working with people in their space. And I think this is actually potentially a really positive thing about a shift from hospital to community, in that we're much more comfortable about supporting people to do what they want in their own environment than we are when people are in our so-called environment. If they're in our hospital, I think we perhaps perceive those risks differently, and certainly there's a different power balance there. But taking risk is a human right. We all take risks every single day. And Martha, I hope you and your dad don't mind, but I'm going to go back to your brilliant log flume photo, because what Martha didn't tell you is that her dad is also an OT, and what a brilliant example of an OT enabling risk than him sat there gleefully with his two terrified children either end of it. We love a bit of risk, and you know, it's a calculated risk, and we have the right to do that. I broke my toe getting out of bed yesterday. Literally broke my toe getting out of bed yesterday.
She's a copycat.
I know.
Right, she was just trying to level the playing field.
I was like, I really want some crutches too. And that is my right. That doesn't mean I'm going to burn my bed and start sleeping in a hammock. It is my right to take that risk. It's my right to go on a log flume. It's your right to go on a log flume. So I think we're in real danger of demonising risk, when actually it's a right that we all have. And I completely understand the anxiety about it as a healthcare professional. And we live in a litigious society. But I think it's not so much about eradicating risk. It's having really open, honest, frank conversations with people about risk, and enabling them to make that choice. You know, I could advise you something as an occupational therapist,
and I would ignore it.
Exactly, and that is your right. That is. You know, it sounds glib, but that is your right. You know, you are an autonomous human.
Yeah.
It is your right to make mistakes. It's all of our right to make mistakes.
And also the risk that we all face is so as a child growing up, when it was deemed that my disability, my cerebral palsy, was the thing that needed fixing, that I was the one that needed fixing, that there was a risk that I might end up in a wheelchair, and my mental health was not addressed. I got so mentally ill that I started to take risks, but also before that, I think, because I was so angry. I was so angry I wanted to prove all the time growing up that I could do everything just the same as everybody else. But what happened when the system, when I was kind of brought into the mental health system and I left school and I became in the psychiatric world, I started to carry on doing that, and just to prove a point. And only after all of this time and so much therapy can I realise I was cutting off my nose to spite my face to prove a point. But that, like, I don't know if that makes sense, but like it's you know, where's the balance? Actually, we do need to be thinking about people's mental health and as much as their physical health. And yeah, sorry.
Absolutely, no, you're right.
I think that's a perfect. I'm so pleased to say, Martha, you've had the last word, as it just exactly as it should be. If I could, everyone could just join in thanking the panel. Thanks very much for your time. Handing over to you.
You're a good boy at the back. You're a good boy. It's a big stretch.
He's bowing.
He's bowing.
Okay.
You're a good boy.
We're going to stay here, so if you want to, you are staying here. Yep.
It is all about Greg, after all.
I'm going to just say a few words to finish off. I hope you all notice, those who are close enough, that whenever anybody claps, Greg stands up. I think he does believe we are all here for him, and that it is all about him. And who knows, maybe it really is. So, first of all, I know I'm standing between you and lunch, and so it'll only be a couple of minutes. On your tables are evaluation forms. It would be really, really great if, when I finished, you fill in your evaluation forms. We will send you a digital one, but you won't fill it in. So shall we all know that about ourselves at this point, understand that and have that insight, and fill it in for the 3 minutes it will take you to do it? Of course, if you know about yourself that you will fill in a digital form, then that's great. I know myself. I know I never would. I'd promise, but I wouldn't. So, Tone said, looking differently always leads to doing differently. And I would like to think that hearing differently, talking differently, being in a different space, as I hope we've created over the last day and a half for this group, is an opportunity for us to do differently. There is no purpose in the Nuffield Trust and what we do if we don't create real change. I talk quite a lot within my role now about purposeful work, and I hope this felt purposeful to all of you over the last period of time. And that by looking, thinking, and interactingly differently, we can do differently. Chris Whitty could have said something that we could take on as certainly the Nuffield Trust's other second byline, which was data almost always wins, which I wrote down. I was like, I mean, I love the man. Let's be clear. Everybody knows me, knows he could have read out the train timetable and I would have been, yeah, I think that's brilliant. I don't know if it does, but gosh, I hope he's right. I really, really hope he's right that data almost always wins. One of my other favourite quotes of the last day and a half, which, can't see if she's still here, talked about having it tattooed, was, you can't cherry-pick candour. And that's absolutely true. And that was the wonderful Lynn from the Metropolitan Police who said that. And that really linked for me back to what Chris Whitty had been talking about how we manage in very complicated times that we have. And all we can do is probably not cherry-pick candour. Another phrase from Tone, which I will probably take away with me, is the poverty of our wealth. And he used that in many, many ways to demonstrate the choices that we make and how we can use our wealth wisely or less wisely as we go out into the world. Fundamentally, we did talk about trust, and we did talk about hope, and we talked about candour, We talked about big things. And I think that was right for these times. I hope you did too. It felt like a place where we could think and think collaboratively and think together. And that's what we always aim to do when we bring such remarkable people together in this room. I hope you have very much enjoyed it. I would really like to thank all of those people who sit at the back and make sure that this runs well, and had a nervous breakdown when my slides didn't appear. And I was fine. But they make this what it is. They really do. They feel very sad that lunch was not outstanding yesterday. So today you have so much lunch available. You are going to have to eat an enormous amount. But they do a fantastic job. So finally, could we maybe just thank everybody, and Greg will know it's for him. Okay, thank you.